Thank you very much for the invitation to speak at this important international workshop on hepatitis B. I'd like to thank Harry and the faculty for inviting me to speak on what is a quite challenging topic in 15 minutes and to focus on new antiviral targets, core capsid inhibitors, and to give you an overview of the data. I'm deliberately going to focus on the data we saw from the EASL meeting earlier this year, as I felt that that is more formed, and I think that will generate more discussion. These are my disclosures. I very much feel that we need to be a little bit more provocative with regard to the data that we're seeing, and I like this quote from Walter Lippmann, which tells us when everyone thinks alike, no one thinks very much. And I'd like to thank those who provided me the slides at short notice as I skip through these slides and hopefully highlight the key issues with the data that we're seeing. Capsid assembly modulators are now really important in the field of cure for hepatitis B. They're probably the most established mode of action of therapy along with siRNA, and in essence, everybody's got one at this moment in time. In this slide, from a very nice review from MFUN and colleagues earlier this year, we see those drugs that are in red that are now in clinical trials. And also we see both those in class 1 and class 2, which demonstrate the different modes of action that we think about with regard to core protein allosteric modulators. In class 1 CpAMs, we see the formation of aberrant nucleus capsids, and in class 2, we see empty nuclear capsids being formed. And there may be some differences with regard to the function and certainly the impact this may have in the context of cccDNA influence or amplification. How do core inhibitors work? They work in several ways, and several active discussions are going on around the impact of these various mechanisms. They essentially target multiple steps of the HBV life cycle to suppress HBV DNA, pregenomic RNA, and cccDNA, and clearly cccDNA influence and diminishment is going to be critical in the world of potentially functional cure. They act here in pgRNA encapsulation to influence and decrease the formation of RNA-containing particles, to also disrupt and cause disassembly, and likewise, lastly, cccDNA amplification. And this, I think, is going to be the key as we see longer-term data as to the longer-term effects and influence on CCC amplification and diminishing that amplification as we see in various phases of hepatitis B. This is a stereotypical output that gives us a sense of the decline that we see in HPV DNA in a phase 1 study from our colleagues at Roche. This was presented last year in EASL and tells us and shows us that decrease in log over a short period of time can be fairly impressive, profound, but there is an associated rebound. This is important, but actually our interest now is looking at the newer markers as we start to understand what I've just talked about with regard to the relative effects on different components of the HBV life cycle as we understand what CpAMs can actually deliver. I'm moving fairly quickly on to the assembly pipeline, and Assembly as a company seem to have really doubled down on core assembly modulators. This is the Bekavir or 0731. These are complicated studies, so I'm going to ask you to focus on the red squares. This is a study presented from EASL by my colleague Scott Fung, looking at e-antigen negative hepatitis B patients, comparing placebo and nuke therapy with Bekavir and nuke therapy, and then a long extension study, which I think is relevant and important as we see longer term data. And here you can see the addition of Bekavir to nuke therapy certainly increases HBV suppression at a very high level with regard to a very sensitive assay. And likewise, the addition over time of Bekavir and nukes increases the suppression of DNA. Moving across to the other panels, we can see that looking at pre-gRNA and using a composite output of DNA and pregenomic RNA, we see that there is good suppression and an additive suppression with capsids in the context of nuke therapy in e antigen negative patients. Across time, we see deeper suppression and decrease in correlated antigen and surface-related antigen. And this clearly shows us the proof of concept of adding CpAMs to existing therapy. It probably delivers more profound viral suppression and additional suppression of pgRNA. And the critical question is what is the longer-term clinical significance of this with some of the other biomarkers we're utilizing, and what might this translate to clinically? And that is really important for us as we assess this area of cure therapy. And lastly, the fairly safe review here with only one patient discontinuing due to rash. Flipping over to e antigen positive patients, and a theme of many of these presentations is the small cohorts and the different populations. This is again from MF, who's really dominating the field of cure, and these newer commercial studies looking at not only treatment naive e antigen positive patients, but also virally suppressed patients. Again, this is important looking at the longer term follow-up and the open label follow-up. And you can see here, both with HBV DNA and also pregenomic RNA, comparing the gray lines to the red lines. The gray is just nuke therapy alone. The red line is with Bekavir, the 0731. You can see that there is a steeper decline and a deeper suppression of HBV DNA. And likewise, we're seeing that with the addition up front of 0731, and also when it is added at week 24. You can see here also the duration of follow-up, which is again critical as we see very short-term data generally in all modes of actions and classes of drugs in hepatitis B at this moment in time. In this presentation, what is important is that with e antigen positive patients, 40% over time achieved a 0.5 log decline in surface antigen. This is not stunning and impressive compared to other modes of actions of drugs, but it is worth mentioning that this is more obvious in the e antigen positive cohorts that have been studied so far. And likewise, Assembly were aggressive with regard to this cohort. It's a small cohort. They followed this cohort out for a long period of time, utilizing this composite marker of DNA and pregenomic RNA at a fairly low level, seeing that up to 3/4 of patients at 72 weeks were negative at both these markers, and then were fairly brave in undertaking an assessment of whether they could achieve a quote-unquote sustained virological response. In this study, we see a press release early looking at the relapse rate associated with the 211 study, with patients followed up between 12 and 18 months. And unfortunately, what this experiment, for want of a better phrase, demonstrates is that all but 2 of the patients relapsed. So we see from this first generation capsid that this will be not enough to achieve control of surface antigen or even relapse or control of HBV DNA. Moving now to the Janssen study, somebody called Harry Janssen presented data from EASL looking at the J&J 6379 CAM. This is a group 2, class 2 drug, and this is the JADE study looking at 24-week data. Complicated study looking at not only e-antigen negative and positive patients, both not treated and virologically suppressed, but also looking at 2 different doses of their capsid. The numbers are not huge, but they are better than what we're seeing in some of the phase 1 studies. And again, what we're seeing is with both the doses, a suppression over and above nuke therapy alone in not treated patients and also in virologically suppressed patients. That's both e-antigen positive and e-antigen negative patients. I'm going to shout out here for the demographics of this population, and like many of the early studies we're seeing, this had a balance of Pan-Pacific Asian and Caucasian patients, and I'm just making the plea that we need to have studies that have the global representation of hepatitis B patients in the early studies so we can understand the heterogeneity of hepatitis B. And I think this remains a work in progress and a topic for discussion. Hepatitis B is a global disease, and we need to recognize that in these therapeutic studies. Going back to the data, we can see that surface antigen in the e-antigen positive treated patients decreased a reasonable amount in the higher dose, but really did not seem to move at all in the virologically suppressed e antigen positive patients and the e antigen negative patients across the board. So in summary, this is an important work that was presented as an oral presentation in EASL, demonstrating that overall safety was good and that the 250 milligram dose had an additive effect on HBV DNA reduction in e antigen positive non-treated patients. Important to highlight that there were some viral ALT flares, and I think these do need characterization, and how the community evaluate flares in general, I think, is an important topic for discussion. And importantly, we also highlight here in this presentation, and again, it's across the field with these agents, that there is breakthrough and resistance via selection if you use capsids as monotherapy, and by and large, this is with the T33N resistance-associated mutation, and therefore it's unlikely that capsids are ever going to be suitable as monotherapy. They're going to be used with a backbone of nuke therapy to try and deepen suppression and or in combination. To give you the breadth of what we're seeing now in the field, again, this is data looking at another class 1 CpAM. I've showed you a class 1, 2 class 2s, and now another class 1. This is a largish study given the field at this moment in time, coming out of China, looking at 110 patients treated for 24 weeks. All of these patients are e antigen positive, and again, a cohort of treatment naive and virologically suppressed. And again, looking at the red highlighted area, you can see that in both treatment naive patients and virologically suppressed patients, you're getting an additive suppression in DNA and pregenomic RNA. It's important also to highlight in the e antigen positive population, those who are treatment naive seem to have a greater chance of achieving a 0.5 log decline compared to those who are on entecavir alone. So almost 50% of these patients achieved a 0.5 log at 24 weeks. Again, showing us that over a longer period of time that we may be seeing a secondary effect by diminishing cccDNA amplification, and therefore seeing other effects that may provide a more formed, clinically significant outcome with the use of these agents. But we just don't know at this moment in time. This is merely to highlight the Allergos data. This is in preclinical models, but demonstrating that we're going to see more CAMs coming into clinical trials. And this seems to be in vitro to be quite a potent new capsid assembly modulator that will be coming into clinical trials in Q1 of next year. And we certainly look forward to being involved in that. This is another study now looking at a second generation capsid and looking at the assembly data, showing again 14 days and a log and DNA change of between 2.5 in a small group of patients, 7 in each cohort, looking at various doses, and we can see the 300 milligram dose will be taken forward. And this doesn't project well, but this demonstrates that certainly Assembly have looked very hard at HBV core inhibitors and demonstrating that amino acid substitutions at the binding pocket can demonstrate differential changes in susceptibility, and show us that here entecavir 0731, 2158, and then 3733 also then increase in potency. And likewise, we see better coverage with regard to the nominated resistance-associated mutations that we may come across in clinical practice. So this is an increasingly exciting field with nuanced new core inhibitors coming into clinical practice at a very rapid pace. So because Harry's now based in Toronto, I thought this quote would be useful. This is from Wayne Gretzky, telling us that pressure is a privilege in the context of the development of all drugs in hepatitis B with regard to functional cure, but particularly I'd say it's very competitive in the field of capsids at this moment in time. So a good hockey player plays where the puck is, a great hockey player plays to where the puck is going to be. And I might suggest that in hepatitis B, we're not even sure which puck we're using at this moment in time if we're thinking about functional cure. But enough of that. I'm really highlighting here, and it's for others and Marion to talk to, the importance of CpAMs and capsids and core inhibitors in the context of combination. And I'm just highlighting one study that's ongoing with Roche. There are many, many other combination studies going on. And in this study, they're using the CpAM in conjunction with a TLR7 agonist. So there's no doubt that the data we're seeing with regard to CpAMs has now meant that they're established in the field and will be a backbone in the combination therapies that we'll be using with regard to consideration of functional cure. So to summarize my talk and a roller coaster of 15 minutes or so on CpAMs, we are still learning a lot about this class of drug and certainly its effect on surface antigen in different types of hepatitis B. That gives us a hint that there may be modulation via an effect on CCC amplification, and longer term studies will give us a little bit more of a feel for what that clinically is relevant. We have a lot of promise and now a lot of early data in this field with multiple players coming into clinical trials and generating data. And they certainly seem to add something and deepen the suppression in addition to nuke therapy. And that is certainly a step forward in the field with this class of drugs. I would highlight again that one size may not fit all, and we saw a slightly differential effect with regard to some of the biomarkers with regard to e-antigen status and certainly treatment status. And I would highlight the heterogeneity of hepatitis B and the need for us to have bigger data sets and longer term data sets to, number one, assess the longer term effect of this effect on CCC DNA, and really to understand the differential effects on different phases of disease. It's clear that this will not be a monotherapy option. There is viral breakthrough with monotherapy, and this will be a combination either with a nuke for long-term suppression, as one company is certainly taking forward as a route to licensing, or likewise as a combination with many of the other mode of action drugs that we're going to learn about in the subsequent presentations and hopefully in the discussion. And lastly, the safety profile is moderately established with regard to this mode of action of drugs, although I'd highlight that vigilance as we go out to longer term follow-up is always going to be important, and this is really a relative statement. So there's no doubt that learning and understanding the study data that we're seeing really gives us some simplicities to take forward for the field as a whole in how we manage flares, how we manage discontinuation, and really the level of suppression and the biomarkers we want to use to try and give us insights into what will achieve functional cure. So at that, I will finish and thank you for my attention and hand back to the chair. Thank you.